Here are the details that every American needs to know about this plan.
Medicare will become law on July 1st, 1966.
I want America to have the finest health care in the world.
This healthcare system of ours is badly broken, and it is time to fix it.
Well, we spend $2.7 trillion every year on healthcare.
Our healthcare is too uncertain and too expensive, too bureaucratic and too wasteful.
This legislation will not fix everything that ails our healthcare system, but it moves us decisively in the right direction.
And we will always protect your Medicare, and we will always protect your Social Security.
This is what change looks like. This is what change looks like.
Dr. Josh Luke, how are you doing, sir?
I'm great. Thanks for having me. Happy to be here.
Absolutely. Absolutely. And thanks for coming. And where do we find you today?
Well, I'm a Southern California guy. I'm actually kind of in transition out towards Arizona. I teach at a Christian university in Southern California. I've been teaching at the University of Southern California for several years, but as my kids graduate from high school, and my middle son graduates tomorrow, and then my daughter graduates next year, we're kind of moving out towards Lake Havasu City. It's kind of the new home for us.
I love it. I love it. Yeah. Southern California has always been big for me. I love San Diego, LA. I guess is LA Southern California?
Yeah, for sure.
Okay.
For sure.
Okay, cool. Then,
in fact, we're more known as Southern California than San Diego. San Diego's actually likes to be known kind of separately as its own, just San Diego, whereas SoCal is usually Orange County, LA County, Ventura for the most part, Riverside, Inland Empire, stuff like that.
Yeah.
So.
Awesome. Well, again, man, really appreciate you hopping on. And, Dr. Luke, really what drew me to you was the fact that you speak it the way it is. And, you've had a ton of experience. And what I love about it is that, you don't really hold anything back. And this is why it's super exciting for me to ask you this question is, as we stand today, right, we've just, we're in the process of going through a pandemic. As we stand today, how would you define where we are as a healthcare industry?
Yeah, honestly, so much has changed. So let me answer that question two ways. First, pre-pandemic, and I have 3 books that talk about this at length. This is a system broken beyond repair, and that is the name of one of the chapters in I think my first book, which is called Ex Acute: A Former Hospital CEO Tells All on What's Wrong with American Healthcare, and it truly is a system broken beyond repair until we as consumers engage in the process, just like we would if we buy a car or buy a house. We need to become engaged healthcare consumers. And we're starting to do that. And the pandemic really fast forwarded that transition. So that's one of the positives that came out of the pandemic. And let me give you an example of that, and then I'll answer your kind of post-pandemic question about where we're at. Telehealth and remote monitoring, but particularly telehealth consults with doctors, whatever it might be, they've been using those with great success overseas, even in third world countries for, 10, 15 years. Yet here in America, we just couldn't figure it out. And it's just another one of those things that's a victim of the capitalistic system that didn't see how it could generate additional revenue. And it was a threat to physicians and hospitals and others. So there's been red tape everywhere. And let me give you an example of that. Doctors couldn't practice over state lines, even on telehealth, right? The feds weren't reimbursing telehealth very much, so to say, in many states. So there really wasn't a rush to adapt it. And then here comes the pandemic. And overnight, they approved things that had been on the table for 10 years and couldn't get support. And also, what happened is that you and I gave our approval because we were forced to engage in the process. My doctor, Ned, wouldn't even let me go unless I did a consult first. So not only did the feds remove the red tape, but consumer adoption happened overnight during the pandemic. And so to answer your question more broadly, now that I've given an example, I believe that Americans are a lot closer now to being ready to becoming what I call EHCs, engaged healthcare consumers, than they were pre-pandemic.
Yeah, and it's funny you say that because I've been utilizing telehealth in a sense for it's been over a year now because I don't want to go to the doctor, right?
Sure.
I'm a millennial, right? And you talk about this in your talks, right? Like
Sure.
we're the ones where when, you basically we're digital first. And so, what do you see when it comes to telehealth coming? Do you see these policies sticking from a federal level?
Oh yeah, for sure, for sure. And part of the reason is there's an old guard of physicians that's really kind of on their way out, and the new guard, the younger guard, are mostly millennials who have been wanting for this. And let me give you an example of that. I have doctors come into my hospital, not so much millennials, but kind of the I guess the younger Gen Xers that got through their residency, and they've never done anything in their residency other than electronic medical records, all online. Then they get to my safety net hospital where we can't afford electronic medical records, and they literally would say their first week, "I don't know how to write in a chart. I've never had to do this before." You know what I mean? And the leaders of those hospitals were, with all due respect, they were fossils. They were these doctors that had been there 30 or 40 years, and they didn't want to learn anything new. They didn't want to give up control. They didn't want to give up their comfort level. And so I think the pandemic is really going to serve as a milestone as to where both the industry and consumers said, we have to flip that switch. We did flip that switch. And there's really no excuse beyond greedy capitalism and people shutting it down to not do that.
Yeah, absolutely. And when you talk about hospitals, right? Like that's where you were CEO of a hospital system, and that's really where you speak a lot about. I know that as we move into the value-based care, and I think that saying nowadays in 2020 that we're still moving into value-based care, I would say that we're probably not still, like, we've been talking about value-based care since like 2008, right? So like I feel like most people agree that value-based care is the new norm, like where we need to be headed. But do you see like the things like telehealth or digital health or this new guard of physicians coming in? Do you see them being more value forward, or are they still being taught the fee-for-service landscape?
Well, as you know, Ned, not all of my answers are all that popular with my former CEO buddies and healthcare executives. And with all due respect, and I always say when I'm a public speaker, so I always say this when I speak, I can say this because I'm one of them, but healthcare executives are the most arrogant people in the world. When you sit there in an audience, the first 5 minutes are like, okay, kind of convince me why you should be up on stage and instead of me being up on stage talking. And really, my emergence from the C-suite. So I had a unique upbringing, if you will, in healthcare. I was a nursing home administrator first, and then I got recruited to be the CEO of this small aging hospital in Southern California because it had a nursing home that it couldn't keep full, because it had a psychiatric unit for seniors that it couldn't keep full. And they knew that I'd proven myself in the Orange County market as a young, energetic healthcare administrator who could fill buildings like that. And they knew that if I could fill those two buildings on their other campus, that the hospital would take care of itself because of the overflow from those two units. And they were correct. I did that for about 4 years, became a hospital CEO. And then when Obamacare passed, I wrote the first book on hospital readmission prevention. It's a new penalty. It was unfamiliar to everybody. I started writing the book in 2013, okay? Like actually started researching it in 2012 when one of their members saw me speak and asked if I'd write the book because I had that post-acute and acute background and it was kind of unique. And it took me 2 years to research and write the book because nobody wanted to talk about it. And at first I was scratching my head like, well, everybody is talking about it like they know something. But then when I say, hey, I'm writing a book, let's sit down and talk, nobody calls me back because I realized nobody had any answers. And more importantly, it was punitive. Readmissions is against how hospitals are reimbursed, right? They're reimbursed for a head in a bed. So here I am writing this book on how to keep heads out of beds. And so I founded a not-for-profit. It's still online if you want to check it out at nationalreadmissionprevention.com. It's the National Readmission Prevention Collaborative. And we just shared best practices, and we have a bunch of resources now. You can actually get certified now in readmission prevention. There's CEU on that website. You can do online CEU if you're a nurse, doctor, pharmacist, nursing home administrator, all about readmissions. It's really been a successful not-for-profit venture, if anybody's interested. But what happened is that's what gave me the street cred to be up there. Okay, I was a hospital CEO. I have a PhD. I wrote the first book on readmission prevention. It became their bestseller for the year. Then I put out my next book that I already mentioned, Execute, a former hospital CEO tells all, and that actually became a bestseller on Amazon. And so when I say there's an arrogance, and there's still a lot of people, even when you have that street cred, that they want to knock you off their pedestal, particularly when you are kind of the you're talking about, hey, hospitals have to transform to value-based care. And to answer your question a little differently, Ned, hospitals did not prepare for, accept, or lift a finger to transform to value-based care until President Trump was elected and 3 failed attempts to undo it. And then they all kind of went, ugh, dust off those plans that we talked about and pretended like we wanted to do for the last 7 years. And we need to implement them overnight now or we're going to be in trouble.
Well, what is that obstacle? Like what obviously the money, right? But what is the biggest obstacle of value, I guess, in the hospital world becoming the main sentiment of executives in those hospital systems? What's going to drive them to that?
The top 3 things are money, money, and money. The fee-for-service era, for those of you unfamiliar, that's the reimbursement model before Obamacare or the Affordable Care Act, is simple. You put a head in a bed and you get paid. If you're a hospital, you find a reason to justify putting somebody in a bed, you get paid. If you're a doctor and you call and say, hey, doc, I'm having a stomach ache, can you help me? They don't get paid unless you come see them. So you put a head in a bed, you bill whoever, and they pay you. Value-based care reimburses you in an opposite manner. It reimburses you for keeping the patient healthy and at home. Yeah. So hospitals obviously were very threatened by that. And if you're familiar with the Kaiser Permanente model, really Obamacare is pushing everyone towards that model. And let me simplify it for you. And a lot of people didn't like this and pretend like they didn't hear it, but it's a fact. It's an insurance model. Okay, the bottom line in an insurance company is if people stay healthy and out of the hospital, you make lots of money and everybody's happy. Now, Kaiser owns an insurance company. They own the physicians and they own the hospitals. When I was a hospital CEO, every month we would have a management operations review meeting, our MOR meeting. And we knew a day or two in advance if it was going to be good or bad, if we made money or if we lost money, right? It was simply my CFO handing me a spreadsheet and telling me if we made money or lost money. If we made money, it was a short meeting, everybody was happy, you went and you grabbed a nice lunch afterwards, okay? If you didn't make money, you had to come into that meeting like armed, like just, ready with the equipment on to escape the bullets flying at you from the corporate office, right? With what happened and what went wrong and, prove to us we're wrong or how you're going to make this up. And so what I explained to people in an insurance model is, do you think Kaiser has an MOR meeting with their hospital each month to see if they made money? Well, they probably do have an MOR meeting, but it's not to see if they made money. They want to make sure that they are being as efficient as possible, charging as little as possible, because the consolidated bottom line of the insurance company is the only one that matters. And that's the new model from the Affordable Care Act called value-based care.
Yeah, and I've heard you say this previously about value-based care isn't readmission prevention, it's admission prevention, keeping people at home healthy, right? Like when in your book Execute, which I do believe everyone should read, it was extremely eye-opening for me. You go literally through this long convoluted step of the 65-year-old guy with hip pain, right? Yeah. And for me, it was one of those things where one of the last sentence of that entire walkthrough baffled me. It was because he had hip pain and needed a Motrin, right? And he went through all of these. He went to the hospital. He went to it was crazy. He went to a specialist. And for me, I work with MA plans. I'm working with, IPAs, large physician groups that are at risk. And for me, it makes sense that wouldn't be the right thing to do, not only from an ethical standpoint, but also from a financial standpoint when you're at risk. That seems asinine on all levels. But are you seeing that journey still happen today? Or are you seeing more push towards that value base, like, hey, we get a certain amount of money to take care of our panel. Let's make sure that they stay home. Let's make sure that they get the care that they need, but we're really preventing those big, actions.
Yeah, it goes back to your first question, and the pandemic kind of put the exclamation point on the transition and transformation to value-based care, because the hospitals were so desperate to empty their hospitals out to prevent the spread of the virus, that they were, it's funny how overnight you can figure things out when it's like, we can't have a single person here that doesn't belong here. So no, that test isn't necessary. It's not justified. I'd sit through 2-hour meetings where doctors argued over whether or not that test was justified for years over a single test for 2 hours with egos involved and everything, you know? And as soon as there's a pandemic and it's black and white, nope, not going to happen. On to the next one. There's no, you know, pushback from anybody because it's not about their pocketbook. But, you know, in that same book where you mentioned the hip pain with Motrin after 3 pages of what the senior had to go through, there's another chapter called the quota-based physician. And those doctors at Safety Net Hospital in particular, they were all about, hey, I have to admit 10 patients a day and, you know, see 7 patients a day in the hospital, and then, you know, visit 3 per day in the nursing home in order to make my X amount of dollars a year. And when they did that, they could make $700,000 or $800,000 a year just from Medicare, as opposed to the, you know, 200,000 or 300,000 they would make if they were just doing the right thing and responding to the needs of their patients instead of trying to churn a quota. So that chapter actually got the attention of the feds, and they called me back and said, hey, tell us about this. Tell us who you're talking about. And I said, I'm talking about the most active doctors in almost every safety net hospital in the country. You just go look at their volumes, sit there for a while, and see if they're doing things in the manner that you would like to see them doing them, and you're going to learn a lot.
Yeah. Now, what if we go broad again here, when you're talking about that, how do we get, you know, obviously it's money, right? Follow the money, but how do we get to the point because we know that we have to better incentivize value-based reimbursement. But I think, how do we move the needle as, like, we know where we need to go as an industry, but where's the how? How do we actually do that as a whole together?
I really think it lies in the hands of the consumers. And over my shoulder, you see 3 books. Okay, I mentioned the readmission prevention book. I don't think you see it there. It might be like over this shoulder somewhere. No, I don't see it over there either. But it's actually underneath those books. There's like 9 copies of the readmission book. But in any case, the readmission book is academic. If it's of interest to you, every hospital should have a copy. But these 3 books over my shoulder, let me explain. The white one in the middle, Execute, you've heard us reference. It's for consumers. It's for professionals. It will open your eyes. I guarantee you won't be disappointed. Short chapters, to the point, lots of excitement. But the other 2 on each side are both called Health Wealth. One, Forbes actually came to me. They saw me on LinkedIn. I got a robust following on LinkedIn. I would love for you to follow me. It's a Dr. Josh Luke. And they said, hey, we see how people react to your very in-your-face posts about healthcare transparency and the lack thereof. Could you write a book for American businesses to teach them how to save significantly on health benefits each year, because it's bankrupting American businesses, the cost of health benefits? That one went to bestseller because Forbes promoted it on launch day. And so many of my friends are like, dude, I'm glad you're a bestseller and that book looks cool, but I don't own a business, because that one's called Health Wealth. Is healthcare bankrupting your business? 9 steps to financial recovery. So I followed it up a year later with Health Wealth for You, 11 steps to save big and live healthy, which I was blessed to see that also go to bestseller on launch day. But here's the point. The point of both the books is become an EHC, an engaged healthcare consumer. The pandemic literally, you know, fast forwarded that times 5, okay, where we now have to pay attention to our health. Americans were reprogrammed just to think about the basics of healthcare, like, you know, just washing your hands and germ exchange and things like that, that in the hospital, you know, we're paying attention to every day. So in order for the health delivery model to change, it's going to require the consumer. And as you mentioned, the millennials like yourself have always kind of been raised in this mindset. And so it's about us unlearning as Gen Xers and boomers that healthcare shouldn't be reactive, because the reactive model that we've now been a part of and inherited costs the average American family $23,000 a year before they see one doctor or get one prescription. So that's not acceptable. And that's not, the average American can't afford healthcare, right? So 23 grand before you see a doctor get a prescription, we have a problem. And until we engage, and both of these Health Wealth books are about you becoming an engaged healthcare consumer, and they give you tools on how to do that, not much is going to change regardless of what the health systems do.
Yeah. And that with, I know that you actually offer quite a few like free tips when it even comes to this kind of stuff. And we'll put all of this in the show notes. We'll link to every one of your books. And one of the things that caught me, like right when I first started following you, was the tips to spending less on healthcare.
Let me tell you about those, just so
the messages
are right. So I have a new website. It's a not-for-profit foundation. And like I said, you can do it in the show notes, or you can just write this down. It's easy. Spendlessonhealthcare.org. Spendlessonhealthcare.org. You can go there and sign up for the 10 free tips to spend less on healthcare. Or if you're driving right now and you get to a stoplight or something, or if you're just sitting around, you can just text the word Josh, Josh, my name, to 72,000, and it'll send them to you, and you just download them. And the 10th one of those, Ned, is because those are 10 free and simple tips, guys. They're easy things to do. And right now, with 40 million Americans unemployed a few weeks ago, there's a lot of Americans looking at a $1,500 a month COBRA bill if they want health benefits for their family. Or you can go to my website, and I'm gonna just really quickly in 30 seconds develop a plan for most families who are unemployed right now. You can get, there's two things I want you to do. I want you to look up a direct primary care doctor in your market. And for $150 a month, whether you're insured or not, you don't need insurance. You can go see him or her any time of day. Okay. 24/7, not 24/7, but any time of day. And then for $25, I want you to sign up for a telehealth platform, Advo Health. Okay. You can go to advohealth.com. So for $175 a month without insurance, you have a doctor 24/7 that can write you prescriptions. That can tide you over until you get a new job, you get insurance. You don't have to pay that $1,400 a month. And let me give you a COBRA tip too. If you don't know it, you don't need to sign up today just in case you get sick. You can say no, no, no for 60 days. And on the 58th day, if you go to the hospital or the doctor, you now are invoking your right to COBRA, but you have to back pay. So a lot of people say it doesn't make sense to utilize it until you have to. But I just gave you a template for $175 a month to get complete access. If you don't have $175, please pay the $25 to just do Advo Health, where you can get 24/7 access to a doctor anytime you want on telehealth. It's a no-brainer to do that. And that's the kind of stuff you can find at spendlessonhealthcare.org.
Yeah, yeah, no, and I think one of the biggest things with those tips are they are extremely simple. It's literally actionable advice that anyone listening to this can take away and actually spend less on healthcare. What I'm curious to hear from you, since you are someone who travels around speaking and you speak with healthcare executives, what are you like? What innovations in digital health are you most excited about, like coming to the forefront? Or what are the things that you think need to be built in order for digital health to really come to the forefront moving forward?
You know, it's a good question, and I'll answer it in two ways. First, a lot of people go, "Hey, Josh, you talk about becoming an EHC all the time, an engaged healthcare consumer, but what does that actually mean?"
Yeah.
And I say, well, it's a 3P plan, and the 3Ps are have a plan based on personalized medicine and preventative medicine. And as you know, having dug into the two books, the 11 tips to spend less on healthcare and to live healthy. Okay, we talked about telehealth, easy one already, right? And you can do it from your phone. And for millennials, we've had to unlearn as a Gen Xer, why would I waste half my day and go sit in the doctor's office when I have a sore throat, when I can just see a doctor online in 10 minutes? I think a lot of us have unlearned that. But you also have DNA testing, your microbiome, how your gut metabolizes food. People still kind of roll their eyes and go, that's witchcraft when you talk about pharmacogenetics. You can know exactly which medications work on you and which ones don't based on your DNA makeup, but you have to go get your full DNA test. Once you do that, you can know which meds work, which foods are fuels, which ones are blockers. So it's called a full genome sequence. You see it all over the internet with the genealogy companies. Those are just a couple of examples and guys, I would think of it like lactose intolerance is kind of the best way to describe it. We all have friends or relatives that are lactose intolerant. There's a ton of foods like that they give you that feeling where something's just not right or off. And when you get your nutrigenomic makeup, like my wife, for example, corn is a blocker is the term I use. I call them fuels or blockers. And corn's a blocker for her. And every time she has corn chips or anything corn, she says she just doesn't feel good. And, she was advised of that in her nutrigenomic makeup. So you can do pharmacogenetics, you can do the nutrigenomics, you can do the microbiome. But ultimately, if you don't know your body better and you don't invest in your body, nobody's going to. And I'll tell you, the last thing I will say about that is I've heard several stories after I speak when people come up to the stage to thank me or whatever, where the exact medication a doctor was prescribing them for years for a chronic condition turned out to be the whole reason they weren't feeling well, because when they got their pharmacogenetic makeup, it showed that their body does not metabolize that medicine, that they needed to use some alternative medications.
Wow. So it's really about digging into your personal medicine as opposed to kind of just trusting the outside, maybe just bringing everything internally and getting things. Because I know for me, I get my blood work done probably like once every 90 days just to make sure that everything's still working right, doing well. And that's definitely helped me
You're
a
a better
ton
man
when
than
it comes
me,
to,
man. I don't do that often.
yeah, no, it's that one definitely came from after I found out that I was lactose intolerant. And it
Yeah.
was just like, all right, let's make sure that everything's good. So, no, those are massively good tips. So really start to focus on being an actual consumer in your healthcare, not not actually just going to the doctor and listening and then going, oh, okay, cool. That's what's going to happen. Actually, almost being able to go to the doctor and say, hey, doc, this is what I have.
Got to do that, because the
yeah,
doctors won't, and they don't even know what to do with it sometimes when you show it to them. But I can promise you, they're not going to do it for you unless you go, doc, here are the medications that work on me. You cannot prescribe me those. And I will go to another doctor. Put it on your phone. I'm holding up a phone. Imagine your phone. Here's my DNA makeup. They all believe in it. They just the electronic medical records don't support it yet.
mm-hmm.
So you have to take it to them. They kind of do. They kind of don't. They're getting there. But think of it like this, Ned. Think of you have a map and there's just like LA is one dot, and then up north is San Francisco is another dot, but there's no freeways or mountain ranges or anything. It's just, we got to get to San Francisco. Okay, go north.
Yeah.
That's how we've been doing healthcare. And now we need to get you a map that has the different freeways and the roads and how fast you can go and how slow you go, and compare that to how your body's going to feel. So it's a good way to think of it.
Yeah, I've heard someone else say it's like a glitchy GPS the way it's used now.
Yeah, totally.
So, Josh, I really appreciate you hopping on and spending time with us. Let me ask you, where can everyone connect with you? I know you talked LinkedIn, your books. We'll put everything in the show notes, but where can they connect with you?
Hey, thanks for asking. Yeah, and my books are 99 cents on Kindle right now. I did that during the pandemic just as a way to say, hey, if you're interested in reading, don't let price be an obstacle.
Mm-hmm.
I also tell people, if you read one of my books, I will actually send you on my own dime a hard copy of that one or another one. If you do a review for me on Amazon, because I love those Amazon reviews. We always try to get up over 100. So anyway, with that said, you can go to drjoshluke.com. That's actually my speaking page. I am a professional public speaker, as you can imagine. Since March, everything's been canceled. So I spend a lot of time with my family. But we do have quite a few online resources too. If you sell to hospitals, which I know a lot of your listeners do, because they're trying to make sure they're staying in tune with it, we have an awesome online masterclass called Selling to Hospitals. You can find that at drjoshluke.com. We did that live and it's sold out. People were paying $800 a pop and it's sold out.
Wow.
Because we're talking about just kind of the inner workings of the boardroom and the not-for-profit secrets, spending limits, champions, all these different things. It's like a 4 or 5 hour program, and everybody who takes it says that was the most effective, efficient program I've ever taken. We have the readmission certification I mentioned to you. We have a couple other value-based certifications, bundle payment certification and transitional care certification. And for those of you who are brokers, we got into a little bit who's going to change this. It's going to be the consumers, and then the brokers that are going to direct contract with the hospitals. We have a health wealth certification, which is just a way of saying, hey, I'm transparent, and I'm going to put my client first, or we don't want any wasteful spending or hidden bonuses. And the most recent one you mentioned, the 10 free tips to spend less on healthcare. Tip number 10, and again, you can go to spendlessonhealthcare.org to get that. But tip number 10 is actually, you need to enroll in the personal healthcare spending reduction tool. And it takes about 5 minutes. You answer some questions. It says, here's my insurance. Here's who in my family has a chronic disease or not. Here's the medications we take. And then we make recommendations. It's actually free to answer those questions. We give you a quick recommendation as you answer each one. But if you want it really personal to you and a full report, at the end, you can make a donation. I think it's $49 or $99 or something like that to the foundation. And we'll send you a personal email that says, hey, we guarantee you can save $5,000 a year for your family based on these answers. If you pay that money, you get that guarantee, that $5,000 in annual savings.
Wow, that's awesome. And yeah, definitely anyone's going to benefit from that. Let's be real. I'd love to save $5,000. So no, but before I let you go, I want to ask a question I ask everyone on the podcast. And
Sure.
the best way to end this is, what are you most excited about in the future of healthcare?
I think I'm just most excited about change. I'm really concerned about the divisiveness in our country right now. I'm concerned about the media's role.
Mhm.
And whenever you're listening to this, I mean, we're taping this in June of 2020, coming off the heels of a pandemic, the first of our lifetime, whether you're a Gen X or millennials, the first of our lifetime, and immediately followed by a country is divided but being brought together by a cause that's leading to protests. We're going on week 3 now, and it's really giving you pause to go, what just happened the last 2 months where we weren't allowed out in public, and now it's okay for 1 million people to be on a street corner. And here we are that my son's not allowed to graduate from high school because of social distancing. There's a lot I'm just concerned about everything, where things are going. And I want to get back to just loving people and people loving each other and not everything being focused. And I get it's the media that is only pointing out the extremes, that's only pointing out the bad things that happen. And I'd love to see more responsible media coverage. I don't know how we're going to get there. I was an undergrad in journalism. And I just don't know how we'd ever get there, because that's how they make money in a capitalistic society. But I think if we could put the media aside, we'd be a lot healthier society. And I think that goes for healthcare as well.
Cool. Awesome. No better way to end. And Dr. Josh Luke, I really appreciate you spending some time today, and appreciate you. Maybe we'll have you back, and maybe you can dig a little bit deeper into everything that you're doing and everything that's going on.
Let's do it. Thanks so much, guys.
Awesome.
Appreciate you, Ned.
Hey, appreciate you. Have a good one.